Okay, yeah, thank you everybody for joining us. For those of you who don't know me, I'm Katie Kahn. I'm a pediatric urologist here at LPCH, and I have the great pleasure of introducing Greg Tasian. I met Greg through PKIDs actually, and through various pediatric urology societies. And then my primary mentor here, Anisha Patel, has also collaborated with him on research. So Dr. Tasian is a tenured associate professor of surgery and epidemiology at the University of Pennsylvania, the School of Medicine, and his research program is based at the Children's Hospital of Philadelphia, so coming all the way over from the East Coast. He is a practicing pediatric urologist and specializes in the surgical and medical management of children with kidney stone disease. He completed his urology residency at UCSF and pediatric urology fellowship at CHOP. He also earned a Master's of Science degree in neuroscience and clinical epi. He is the director of a 30-site PCORI and NIH-funded Pediatric Kidney Stone Care Improvement Network, which is what we're going to hear about today. And he leads CHOP's Center for Outcomes Research and Surgery. His group uses a combination of randomized controlled trials, randomized trials, prospective observational trials, and large data analytics. And again, we're going to learn a little bit more. And his research program has been continuously supported by the NIH and PCORI since he finished fellowship. He's got a lot of publications out there, so make sure to look him up. Okay, welcome, Greg.
Well, good morning. It is a true honor to be here. And it just started with a really exciting night last night. I see Dr. Shortliff and, all of these intersecting lives going back to training, which is just so meaningful to see because I think as you go along, it's really the relationships that you form and you build and you continue on that really provide that fulfillment in one's career. And, this is a time where you can really realize that. So I'm deeply honored by this invitation. And as Katie had mentioned, we're going to be talking about a comparative effectiveness trial of 2 surgical interventions for children with kidney stones. But I'd like to broaden the conversation and certainly in the discussion to follow to talk about research embedded in clinical care, as Dr. Leonard said, that where it's really within the 4 walls of the hospital that you can generate meaningful results that can then be implemented. I'd like to talk about patient-powered and patient-generated research, where patients and caregivers are partners in research and not just participants. I'd like to talk about observational studies, some of the challenges and opportunities, and really in whatever direction you'd like to go, either content or methodology-wise. So these are my relationships. I am on the scientific advisory board of 2 pharmaceutical companies, neither of which had anything to do with the talk here or the research being presented. This trial was supported by PCORI. And it was really generated by our collective experiences as urologists sitting down with patients and their caregivers in our clinics, and a recognition that there is such little information that's available, high quality information to guide clinical decisions. And oftentimes, and these are quotes from some of the patients that have been treated across the PKIDS Network, that they're really searching for answers, and those answers don't exist. I never had surgery before, so I was really nervous. I went home and researched online how kidney stones passed, how this surgery worked, other surgery options, and people's experience with them. This is a quote from another patient. At that time, he was a 14-year-old who had recurrent stones and had multiple different surgical interventions. And he was reflecting on his first experience, and he simply said, this outcome was a surgery that no one wanted to repeat. He had a different surgery about 1.5 years later, and he said, wow, this experience was so different than my previous one. So it's really these anecdotal experiences that we codified by really seeking input from patients that generated the idea for this trial. That anecdotal experience is really reflected in the evidence base that supports the surgical management of children and adolescents with kidney and ureteral stones. The last time that the professional guidelines were updated were in 2016. It was the first time that we had guidelines for the surgical management of children with stones. There were 8 guidelines, 50% of them were supported by expert opinion. And the one that is relevant to the talk here was that for patients with a renal stone burden under 20 millimeters, so these are small and medium-sized stones, clinicians may offer shockwave lithotripsy or ureteroscopy as a first-line therapy. This is supported by level C, or very weak evidence. That the reason this exists is because the evidence is largely single institution, retrospective studies, or an extrapolation of studies performed in adults for whom the anatomy and the experiences for surgery differ quite dramatically. And no prior studies had considered outcomes that were identified and prioritized by patients. So despite the equal support for these 2 interventions, ureteroscopy, which is an endoscopic procedure, and shockwave lithotripsy, which is a non-invasive procedure where stones are broken up by shock waves, 80% of children in the United States undergo ureteroscopy for these stones. So in order to increase the strength of the evidence supporting these decisions made by patients and their families, we formed a network that is called the Pediatric KIDney Stone Care Improvement Network, comprising 31 centers, 28 health systems in the US and Canada. And really the strength of PKIDS is its partnerships and its diversity. So you have different sizes of institutions, you have different geographies, you have different practice patterns that really reflect how surgical care is delivered through North America. This is a geographic representation of the PKIDS network. So PKIDS, while it does include clinicians, both urologists and nephrologists, primary care providers, and investigators, the strength of it is the diversity within its membership. And it includes patients, caregivers, who we call the patient and family partners. It includes industry representatives, because our goal is not to just generate evidence, but to really implement that evidence back into clinical care so you can magnify the impact. And it also includes payers and health system leaders. And each of these groups have been involved in planning the study, conducting the study, and currently are in conversation for disseminating the study results. So the goal of the PKIDS trial was to improve the understanding of the effectiveness of different kidney stone surgeries and the impact of these surgeries on children and adolescents' lives. So this was a prospective cohort study of individuals 8 to 21 years of age who were undergoing non-emergent kidney stone surgery. The comparators that we'll be discussing here are ureteroscopy and shockwave lithotripsy, an endoscopic procedure, and a non-invasive procedure, respectively. The reason that this was a prospective cohort study is really the lack of clinical equipoise for those 2 interventions. As I mentioned previously, 80% of these children undergo ureteroscopy. So there's a strong clinician bias towards ureteroscopy, making randomization challenging, if not impossible. The primary outcome was selected by patient and family partners. There are total of a minimum of 5 patients and their caregivers within the patient family partners who chose the primary outcome, as well as the secondary outcomes, which were measures of physical, social, and emotional health. The primary outcome of stone clearance, it was defined as the absence of any stone on ultrasound 6 weeks after surgery, with a maximum diameter of 4 millimeters. The reason for this size threshold is that ultrasound is known to overestimate stone size by about 2 millimeters, and 2 millimeters is a commonly used threshold on CT for a clinically insignificant fragment. And most importantly, for residual stones over 2 millimeters, the probability of requiring subsequent surgery due to symptoms is much higher than under 2 millimeters. So the secondary outcomes were largely measured by PROMIS measures, and these included pain intensity, pain interference, anxiety, psychosocial stress experiences, sleep disturbances, and peer relationships. Each of these was selected by the patient family partners. These partners also emphasize the importance of urinary symptoms after surgery, such as hematuria, urinary urgency, urinary frequency. However, there is not a validated instrument to measure these symptoms. So we use PROMIS methodology to develop a urinary symptom score. So this is just a schematic of the relationships between the exposures, the types of interventions, and the outcomes, and all of the different factors that could influence the choice of surgery and or the outcomes that we measured. So in order to really minimize the risk of bias and confounding, we had to measure characteristics not only of the participants, but of the health systems, the surgeons who were participating, the access factors, and the technical factors of how surgery, which is certainly a complex intervention, were delivered. So the PKIDS trial was embedded within clinical care. The choice of surgery was a joint decision made by the surgeon, the patient, and the caregiver. There was no influence by the research design. And after the surgery was selected, the surgery occurred, and there were questionnaires that were administered for the PROMIS measures and the urinary symptom scores before surgery, at the primary time point of 1 week after surgery, and again at 3, 6, 9 weeks, and then 3 months after surgery. The ultrasound was a standard of care ultrasound in which the protocol was standardized across all 31 centers using a template that was developed by pediatric radiologists. And then EHR surveillance was performed to monitor for any events such as ED visits, hospitalizations, or repeat surgery for any of the participants. As Dr. Leonard mentioned, this was facilitated by the fact that many of the sites participate in PCORNet clinical research networks and allowing query of the common data model, of which PEDSnet is one, but not the only CRN represented in PEDSnet, or in PKIDS. So this is the consort diagram in which a total of 1,290 patients were consented and assessed for eligibility. And then the majority of these patients, 963, underwent ureteroscopy, and this represented over 1,000 kidneys or ureters, which were treated as independent entities. And about 189 patients underwent Shockwave, representing 197 kidneys or ureters. The trial opened 1 week before the world shut down with COVID, which represented a substantial challenge, not because patients wouldn't be randomized, but simply because in-person care was deferred, and surgery, while it did occur, was happening selectively, and for ultrasounds, which were our primary means of measuring the outcome, those were often deferred. So the biggest challenge that we had to overcome was how to measure the primary outcome. I think while it was difficult, and that within that 4 to 8 week ascertainment window, about 50% of the patients did have an ultrasound within window. 75% had it when you expanded it to 12 weeks. So while it was a challenge, if we expanded the window, these patients, the majority did receive ultrasounds. Here is just a representative sample of the patient characteristics. The number of characteristics are vast, and we'll go over the high-level overview. But importantly, these patients represent the typical patients that we all see every day in our clinics and operating rooms. The median age for both groups, and this is before balancing these characteristics, were about 15 years of age. The majority were female, again, representing the epidemiology of early onset stone disease. Most were white, which is, again, representative of the epidemiology in North America. The stone location was in the kidney for a majority of patients, but 40% had stones in the ureter for ureteroscopy, and understandably about 14% for shockwave patients. The indications, the primary indication for surgery were elective for both, the greatest indication was elective for both ureteroscopy and shockwave. So this is a representation of the standardized mean differences of the patient, health system, and surgeon characteristics before we weighted on the inverse propensity for treatment in green. So the deviation from the midline represents a greater difference between the two groups before weighting. And then after weighting with the propensity scores, the standardized mean difference for 88 or 86 of the 88 characteristics was less than 0.1, indicating excellent balance of these characteristics. All were less than 0.25. So, and this is just to go a little bit into the technical aspects of surgery, because it's important, I think, to understand this, to really appreciate the differences in the patient experiences. Unsurprisingly, most patients who underwent ureteroscopy had ureteral stents placed. Ureteral stents are a temporary device that's placed from the bladder up to the kidney. They're made of soft plastic, but they're incredibly painful. And they are removed either back in the operating room for children, or if a stent is left with a string attached, the patient or their caregiver can remove that stent at home by simply pulling it in their home environment or back in the clinic. For adults undergoing this surgery, it's often done with an office cystoscopy, which is not something that is done for our pediatric patients. So 79% of patients who underwent ureteroscopy had stents placed. Only 3% of patients having shockwave had stents placed. The median duration of those stents were 5 days for ureteroscopy, 21 days for shockwave. And I think we can understand this difference because the majority of patients who had ureteroscopy had a stent placed with a string, facilitating at-home or in-clinic removal, whereas everyone that had a stent with shockwave had it removed in the operating room. And there's just a greater lag time of getting back to the OR to remove those stents. So that I think the takeaway from here is that about 80% of patients having ureteroscopy had stents placed, only 3% of patients having shockwave did. So this is the overall treatment effect for the primary outcome, which again is stone clearance. There were no differences in stone clearance between ureteroscopy and shockwave. For ureteroscopy, it was about 72%. For shockwave, 69%. A difference that was neither statistically significant nor clinically important. We analyzed for heterogeneity of treatment effect by two different stone characteristics, being stone size and stone location. Stone size was categorized as under 7 millimeters, 7 to 10 millimeters, and 10 to 15 millimeters. Stone location was the ureter, the lower pole of the kidney, and the non-lower pole of the kidney, meaning the mid-pole or upper pole. There were no differences in stone clearance by any of these categories. However, there was a suggestion that there could be a difference in the 10 to 15 millimeter category. When you look at these point estimates and the confidence intervals, they're starting to diverge. And you can see here when we analyzed stone as a continuous variable, you can see a separation beginning at 10 millimeters, where stone clearance really didn't change for ureteroscopy, but decreased for shockwave lithotripsy. I think to us, this represents remaining uncertainty in whether ureteroscopy is a more effective treatment for removing medium-sized stones than shockwave lithotripsy. This trial was not powered to detect these differences by stone size, but I think inform future trials that can really examine for these differences for medium-sized stones. So how did we interpret these ultrasounds? All ultrasounds were interpreted by radiologists at each site using both that standardized ultrasound protocol as well as a template for reporting. However, we recognize that that in itself could introduce variation in how ultrasounds are interpreted. So we analyzed a 10% sample of those ultrasounds centrally at CHOP. It was done by a single pediatric radiologist who was blinded to the treatment group. And the goal there was to provide a blinded interpretation of the ultrasound of whether stones were cleared or not. For those ultrasounds in which the central interpretation differed from the local interpretation, a second pediatric urologist, again blinded to the treatment group, reviewed those ultrasounds and consensus was reached. Only 5% of these outcomes changed on central review. And there was the sensitivity and specificity of the local ultrasound interpretation were importantly similar between treatments. We performed a sensitivity analysis that was weighted with these results of the central interpretation, and those did not change the outcomes. So this is where I'd like to just note how we analyzed these patient experiences, which were the secondary outcomes, not because they were of secondary importance, but simply because our trial was powered for the primary outcome of stone clearance as a dichotomous variable. I would argue that this is the real novel information that this trial provided by measuring experiences that were meaningful to patients and their caregivers. And what we have discovered here is that 3 of these experiences were better for patients that underwent shockwave lithotripsy compared to ureteroscopy 1 week after surgery, adjusting for their baseline symptoms. And those better experiences were better urinary symptoms, better pain intensity, and better pain interference. And you can see the beta estimate shown in the right-hand column, which I think in itself is somewhat meaningless. However, what we want to understand is whether this is a clinically meaningful difference between the groups. And to that, we turn to the literature to help us interpret the change in the PROMIS T-scores. While this hasn't been done for pediatric patients undergoing surgery, a T-score difference of 3 has been considered clinically meaningful for other outcomes in other health conditions. Both of these for pain intensity and pain interference exceeded 3. And for urinary symptoms, which was not a PROMIS measure, we used the standard deviation of the baseline scores to understand if there was a greater than 50% change compared to the baseline standard deviation. And about 40% of patients undergoing ureteroscopy, 27% of shockwave exceeded 50% of the baseline standard deviation, suggesting this was a clinically meaningful difference. So we also asked patients of the time they missed from school in that first week after surgery, and their caregivers the time that they missed from work. And patients who underwent ureteroscopy missed more school in the first week after surgery with a risk difference of 21%. And caregivers had a similar amount of time missed from work with a difference of 23% for ureteroscopy compared to shockwave lithotripsy. So here we're going to pivot from the clinical results of the trial into an understanding of how generalizable are these results to the patients that we are seeing everywhere in the United States, either at centers that participated in the trial, as well as those centers that treat these same patients, but that didn't participate. And in order to do this, we turn to PKIDsNet. And PKIDsNet has 8 clinical research networks that participate in that large umbrella network. And each of these networks have a common data model that allows you to query these health systems to understand characteristics of patients that are seen within a particular point in time or a range, who meet the characteristics of your target population. So here what we did was compare the characteristics of the participants in the PKIDs trial to all patients who underwent surgery at sites, at PKIDs sites that participate in PCORNet and at PCORNet sites that don't participate in PKIDs. So the first one is like, how representative is the study sample to those patients who didn't participate, who declined participation within the same site? The second question is, how representative is the PKIDS network compared to that larger ecosystem of where care is delivered across PCORNet? So the differences were slight but important. Overall, the biggest difference were that patients who participated in the trial were younger than patients seen at sites that don't participate in PKIDs, suggesting perhaps that PKIDs sites see a younger, perhaps more complex patient population than other sites that may be treating older adolescents or young adults who are 17, 18, 19. So that was the biggest difference in terms of the representativeness of the sample. The sex distribution was very similar, as was race, with a slightly lower proportion of Black patients who participated in the trial compared to patients who received care throughout PCORNet. The ethnicity was very similar in all comparisons. And I think this reflects that we used Spanish language questionnaires for promise measures and translated the ICFs into Spanish, so we could really have as representative a sample as possible, reflecting the patients that we see. What we did here was compare at I think, clinically more meaningful level some of the complexities, the measures of complexity for patients that are participating, PKID sites that are participating in PCORNet versus those PCORNet sites that are not part of the network. And we use something called the Pediatric Medical Complexity Algorithm to understand the body systems affected by our study participants compared to those patients of similar ages who had the same surgery over the same time period at other sites. And overall, they were very, very similar, with the exception that patients in the PKIDs trial had a higher proportion of musculoskeletal and neurologic conditions, suggesting a slightly more complex patient population. So the reason that I wanted to really spend some time here is that oftentimes in clinical trials, and I think that's especially true for randomized trials, we're enrolling a very targeted population that we don't have a complete understanding of how representative they are of the larger populations to whom we need to and want to generalize these results. And I think when you can envelop or incorporate any trial, whether it's randomized or observational, within a larger data environment, it allows you to understand how, to what extent, or should you generalize these results to places where that site did not participate in the trial. So there were 4 takeaways for the PKIDs trial. Number one was that clinically, ureteroscopy and Shockwave resulted in similar stone clearance, despite more patients in ureteroscopy having repeat surgery to clear stones. Number 2, compared to ureteroscopy, patients undergoing Shockwave experienced less pain and lower urinary symptoms during the first week after surgery. Number 3 was that patients having Shockwave missed less school and their caregivers missed less work than patients having ureteroscopy. And then 4, compared to Shockwave, 10 times more patients receiving ureteroscopy required a second procedure under general anesthesia to remove a stent. And cumulatively, I think the results help us understand that this real-world evidence calls into question current clinical practice, wherein most patients, 80% of children and adolescents with kidney stones receive ureteroscopy. So for small and medium-sized stones, shockwave lithotripsy seems to be the better treatment. So what are the limitations of this study? Number one, the trial was not randomized. And that was, as I mentioned before, due to a lack of clinical equipoise between shockwave lithotripsy and ureteroscopy. In the extensive preparations for this trial, having conversations with the 126 participating pediatric urologists, it became clear that if the trial was randomized, there would be a distinct lack of enthusiasm for participating, meaning that that decision for a particular surgical intervention did not want to be left to a flip of a coin, and really wanted to come down to that conversation between a patient and a caregiver and a surgeon about what is the preferred treatment. But those decisions are informed by prior experiences, prior training, and own biases. And I'll just share my experience in my training, and that was just up the road at UCSF. The one procedure where I was deficient at the end of my chief residency was shockwave lithotripsy. So I had to scramble in the last 2 weeks of residency to do a shockwave procedure because I just didn't have that experience. So that carried forward after I finished fellowship. And then when I started my clinical practice, I didn't offer shockwave because I didn't know what it was. I didn't know the value. I had my own biases against it. And it was really stepping back from my own biases and really hearing about the experience of patients primarily who had shockwave that changed my clinical practice. But how do we do that at a higher level and more systematically? That's the challenge for implementation, which we'll get into. But that lack of randomization, while necessary, does introduce the possibility of unmeasured confounding and bias. And while we balanced many of these characteristics, the possibility of unmeasured confounding still remains. I mentioned that about 50% of patients had an ultrasound within the pre-specified window. This was largely due to COVID. We were able to mitigate it and understand the impact through sensitivity analyses, where we extended the period to 16 weeks. There were no difference in the outcomes between the primary ascertainment window and the expanded window. The third is that ultrasound, while it is the standard of care and the preferred imaging modality, both for the diagnosis of kidney stones or suspected kidney stones in children and adolescents, and the preferred modality after surgery to assess for stone clearance, there are limitations. It is less precise than CT. It overestimates stone size. And when you have a cluster of fragments, you may not be able to differentiate a cluster of very small fragments from a larger single residual stone. And that's something that is unknowable with this study. But what I think is knowable is that, again, going to the importance of a data environment and infrastructure where you can track these outcomes over time by querying the PCORNet Common Data Model to understand the impact of residual stones and size with unanticipated healthcare encounters such as ED visits or hospitalizations. So all the patients who were consented to participate agreed to have that long-term follow-up. So we would hope in 5 years from now, we'll be able to answer this unknown question now. And fourth, that in these analyses, we didn't consider the impact of analgesics or antispasmodics, such as oxybutynin, on patient-reported outcomes. And currently, we didn't consider the technical aspects that may impact effectiveness. But when we're thinking about implementation, I think you can think about it in two ways. Number one is, how do you change practice by offering shockwave lithotripsy for a patient with a small or medium-sized stone compared to ureteroscopy? The other way you can think about it is, if you are doing shockwave lithotripsy or if you're doing ureteroscopy, how can you do that more effectively? And that's when the technical aspects of surgery come in. You know, how is it that with your laser settings on the ureteroscopy or for shockwave lithotripsy, the rate at which shocks are delivered, the number of shocks delivered. It's those things that I think also present an opportunity to improve care, and those will be analyzed in a second phase. So we already really went over these broad conclusions that shockwave appears to be the preferred modality because of similar stone clearance and better patient experiences. We've talked about the considerations for study design, which I hope we can continue that conversation after I conclude these remarks. I did want to end on 2 points. Number one is the importance of including patients and caregivers in your research, and then also discuss implementation. So this was a humbling experience for me, and it was by far the most transformative experience I've had as an investigator over the last decade, because it was the first time that patients have been included as partners in every phase of research. And it's remarkable when you ask patients what's important, what you will hear, and what you hear, how often that diverges from your assumptions. So simply asking your patients what matters to you and identifying where those boundaries of current knowledge are and how you can design a study in partnership with patients around that meaningful outcome to really generate impactful knowledge that will change practice, that changes and improves the lives of patients is something I would encourage everyone to do. And it starts at the very beginning. But patients are, it's not only in idea generation, they can make your studies more effective and just you can conduct them better. So there are so many times that we turn to our patient and families to help us understand recruitment practices, how to, quote, pitch the study in a way that was accessible and what made the patients and families want to hear more about it. And that continued for the 2 or 3 years when we were enrolling patients, and it made a difference. After the data were generated and we were starting to interpret the results, we sat down with our patients and families and asked them to help us understand what was important to them and how to interpret some of these results, particularly around patient experiences and that intersection between the clinical outcome of stone clearance and how it may intersect with these patient experiences. Again, very important conversations. And then now as we work towards dissemination, we spent 2 hours talking to our patient and families about 2 things. One, how to best return the results of the trial back to the participants, but 2, also to the communities that they represent. And we came up with, or they came up with 8 different strategies, which are not mutually exclusive, but are really synergistic, that go beyond just an email of the study results, which is often what's done. Some of the ideas included having a forum where half of the time over an hour over Zoom, over Teams, would be spent just presenting the results in a language that is accessible. And then the second half would be for a bi-directional conversation, but then prefacing that 1 hour session with like short videos that would be distributed to all the participants that gave a high level overview of what the trial results were, and that these would be filmed by patients and their caregivers. So it would really sort of like prime the pump and give all the participants the opportunity to submit questions ahead of time, give them the space if they didn't want to speak in public to have their question asked. And if they couldn't attend that 1 hour session, that their voice could be heard. It certainly included having a one-page summary that would be distributed not only by email, they were the least enthusiastic about that, but they were thinking about innovative ways, such as using patient portals, which we all have in our own health system that, I think we're familiar with communicating results, receiving questions or concerns from patients, but can we use that as a way to disseminate? I think there are likely differences in policies by different health systems, but something to explore. And I won't go over all of the different strategies here, but more than anything, the one thing that they want to know was the so what. So what do these results mean? So is it enough to say, 71% of patients who had ureteroscopy had stones cleared, 68% of patients who had shockwave had stones cleared? Not really. They want to be able to really glean what would change their decisions, what would inform their decisions when they or others are, faced with these decisions in the future. And then the second part is how to disseminate these results to the communities that the participants represented. Unlike other conditions such as diabetes, there are not many patient advocacy groups. There's not many forums, and it's largely it's very decentralized. The one area where there are communities seems to be in Facebook, and those are often regional. So we're trying to understand how to be able to leverage these existing groups, but come from a position of trust, and that's going to be really important. So how do we, share results both as the PKIDS Network, but also leverage our relationships with other research organizations and clinical care organizations who may have pre-existing relationships with some of these groups. So identifying relationships and trust. And then finally, after dissemination comes implementation. And Dr. Leonard had mentioned that learning health systems are really focused on this virtuous cycle of knowledge generation and application. And certainly when I went through my research training, the idea I had of research was an investigator comes up with an idea, you conduct a study, you conduct a trial, data are generated, results are, the data is analyzed, results are reported in a manuscript, and you move on from it. That impact of that linear model is very limited. What is much more impactful is if you can generate knowledge and then apply that knowledge back into care, so you can directly improve the health of the patients that you serve. And I think when you think about health systems and how you can effectively implement, there's a lot of opportunity, but there's a lot of challenges. So drawing on the experience of the PKIDS trial, we have an understanding of which is the preferred modality, but how do you actually change practice for the 126 surgeons that participated in the trial and outside? It's a question to us of both de-implementation of ureteroscopy. So how do you use ureteroscopy less? And then how do you use shockwave lithotripsy more? There's a lot of factors that go into surgical practices. All of the technology and the advancements are happening in ureteroscopy. So every time you're at the AUA in a professional meeting, you're reading about the new single-use scope, the new thulium laser. It's exciting. That's where all the energy is. Shockwave lithotripsy, while it's been around for 30 years, has not had much innovation. So that's a challenge that we need to address as a profession. I talked about the surgeon skill and surgeon bias that's introduced by prior experiences through training and in practice. But then you also have equipment type and availability. The laser may not be available after hours. If not, you're going to place a stent. You're going to subject a patient to greater pain, greater urinary symptoms, and then have to do the definitive procedure later. Shockwave lithotripsy, some health systems, some hospitals own a lithotripter, but many do not. Those are rented. So that's going to impair your ability to treat children who need urgent surgery and all that coordination that it involves. Some shockwave lithotripters, such as the one that we use, have an inline ultrasound. So you're able to treat, a broad number of stones, despite not being able to see it on fluoroscopy or X-ray. That's great. That doesn't exist with other makes and models. So there's all of these factors that we have to consider that are barriers for changing practice. So that's really where we are right now, trying to understand what these barriers are, try to develop strategies that are going to overcome them with the goal of ultimately improving the health of these patients in the future. So I'm now going to end just with these two images. The image on the left is that brief moment in time right before Omicron hit, where we were able to gather as a network in Miami, and really at that midpoint in the trial, gather as a community of investigators, clinicians, and patients. And that was a really special moment. The second image is also from Miami, where Hunter Beck, who is one of our patient and family partners, came to the Societies for Pediatric Urology and gave a presentation about the importance of engaging patients in research, his experiences of living with kidney stones, and how incorporating patients into research is essential because it just provides the experiences that otherwise you won't have. So I'm very grateful to Hunter and to all of our patients who were true partners in this network and in this trial. Without them, it never would have happened. So with that, I will conclude and thank you again for this kind invitation and attention.